It's good to be here, as Mitch mentioned, and thanks for having me. My name is David Dayen. I'm the executive editor of the American Prospect. We're a magazine about ideas, politics, and power. We write about who has power and what they're doing with it from Washington to the corporate boardroom. We have focused on healthcare over the last year. My colleague Maureen Tkachuk, you might know, and I have done an entire series called The Business of Healthcare, and we did a special issue. We actually still send dead trees to people. We send print. We did a special issue last August on healthcare. And that was the genesis of this article that Mitch mentioned. So I'm going to give a sort of a short history of the federal involvement in the healthcare payment system. As we know, roughly half of the $4 trillion that is paid through the healthcare system comes through the government, through government programs. And so obviously government is a huge driver of what systems happen through healthcare and whether the system is public or private. And what we currently have is a system where a lot of the money comes through the government, but the delivery system is largely privatized. And that's even true of the public delivery system. So how did that start? Like, where does that come from? Interestingly, you can trace it back to the Nixon tapes. If you listen to the Nixon tapes, you can find Nixon hearing about this wonderful system in California called Kaiser. He was interested in the idea of managed care and thought that, you know, capitated payments per enrollee, narrow networks, strong case management, keep within a budget. This was the way to go. So in 1973, we see the passage of the HMO Act. HMOs employ doctors and try to sort of use that budget to play treatments off with doctor salaries. The father of the HMO is a guy named Paul Elwood. He created a think tank that developed this concept, and his top insurance guy was a guy named Richard Burke. And up until last year, Richard Burke was the chairman of United Health. He founded CharterMed, which eventually would become United Health Group. In most states at that time, HMOs, kind of similar to the corporate practice of medicine laws, HMOs had to be nonprofits owned by physicians. And so what CharterMed was the workaround. It was a management services organization that handled billing and handled reimbursement and other monetary issues for HMOs. In 1979, the Federal Trade Commission actually ordered the AMA to change its guidelines and embrace this concept, embrace HMOs, particularly the model where non-physicians would contract to a physician group. Hello, come on in. So United Health eventually took what they learned from the HMO business, applied it to the fee-for-service side of medicine, and merged its way into a very dominant position, and started to apply those managed care techniques, you know, into the fee-for-service side of the insurance business, demanding lower prices from doctors, lower prices from hospitals. HMOs eventually engendered a backlash, but right around that time in the 1980s is where the sort of star of my story, a guy named Tom Scully, comes in. So who was Tom Scully? Tom Scully was first of all, he was a Senate staffer in the early 1980s, worked for a senator. Then he started working for the George H.W. Bush campaign. When Bush won in 1988, obviously what happens is after a campaign transitions into being the government, there are a lot of patronage jobs available. Tom Scully knew nothing about healthcare. He said at the time in 1988, I didn't know the difference between Medicare and Medicaid. But there was a job open in the Office of Management and Budget, and it was a legislative liaison. And he took the open position and became a healthcare expert in after 1988. He took the job. He became responsible early on for two things. One, the attempt to salvage the Medicare catastrophic coverage law that was put in place in 1988. Ultimately, that was unsuccessful. This was a law that said the sickest patients would be covered, for their catastrophic care through the Medicare system, and it would be paid for by the healthier patients. Healthier patients didn't like that. There was a very famous scene, a town hall with Dan Rostenkowski, who was the head of the House Ways and Means Committee at the time, where older seniors stormed his car and started banging on his car. And this very swiftly led to the repeal of the Medicare Catastrophic Coverage Act of 1988, which had a prescription drug benefit and would take 15 years for Medicare to give a drug benefit after that. The second thing Scully did early on, he was responsible for RBRVS, which I'm sure you're all aware of, which is the payment system it was a physician payment reform in Medicare. Ultimately, it did not achieve the goals that it wanted to achieve. But Scully, very early on, became enamored of the managed care concept. He wanted to import it into Medicare and Medicaid. He invented the idea of risk adjustment, where the companies with sicker patients in the risk pool would be paid through various forms of coding to compensate the sicker risk pools at the expense of the healthier risk pools. So he created in 1992, during the Bush campaign, the 1992 Bush Health Plan, which was essentially this. It was premium support for basic coverage, insurance market reforms to prevent adverse selection, strong managed care, strong techniques to bend the cost curve. This never became law, but you might recognize it because it is essentially Obamacare. It is the Affordable Care Act. It was invented in 1992 by Tom Scully. In between Bush administrations, he became a lobbyist. He ran the Federation of American Hospitals. And then when George Bush's son became president, he came back to run the Center for Medicare and Medicaid Services, CMS. Two big things he got done then are both incorporated into the Medicare Modernization Act of 2003. There was a prescription drug benefit in Medicare and the modern version of Medicare Advantage. So first off, the drug benefit, it's all private plans. They don't use bulk purchasing to lower the cost of prescription drugs. The guy who negotiated the bill in Congress, a guy named Billy Tauzin, he was the Republican head of the Energy and Commerce Committee. After the bill passes, he leaves to become the head of the Pharmaceutical Research and Management Association, the trade group for the prescription drug companies. That kind of tells you what the tenor of the prescription drug benefit. And then the second part of this is Medicare Advantage. So Medicare Advantage originally was called Medicare Plus Choice. It was similar to an HMO. The plan would get capitated payments. It would cover within limited provider networks. There was a budget change in 1997 that sharply limited the funding of that capitated payment. Medicare Plus Choice was 14% of the market in 1997 and then started rapidly declining because of this reduction in the payment. In 2003, the Medicare Modernization Act remedied that payment, created this prescription drug benefit, but also allowed PPOs into Medicare. And so now you can get a PPO, a drug benefit, and catastrophic coverage, sort of the Medigap version. You can get that all in one Medicare Advantage plan, one premium. Scully thought this would give leverage to the Medicare Advantage plans to force better quality and lower costs through Medicare. Medicare Advantage, as you know now, is the choice of 48% of all seniors. In the over 65 population, premiums are fairly low. The plans offer gym memberships. They offer other benefits to try to entice seniors. But payments are higher per enrollee than under traditional Medicare. And why is that? Well, there are three reasons. One is risk selection. Obviously, seniors who see a gym membership that are very sick do not need that gym membership. But healthy seniors think, hey, that's a great benefit. The drug formularies weed out high cost patients. They say you cannot, certain high cost cancer drugs are not under the formulary of a Medicare Advantage plan. So this risk selection is essentially cherry picking the enrollees to try to get cheaper enrollees. The second part is gaming risk adjustment through what we know as upcoding. I'm sure this is something you know plenty about. Encouraging doctors to upcode diagnoses, adding diagnoses that don't exist in the patient. Overbilling. One estimate by USC is that there was $75 billion in Medicare Advantage overbilling last year through upcoding primarily. And then the third part of that is simply denying care. So Medicare Advantage rejected 85,000 requests, according to an Inspector General's report, that just in 2019. And what created this dynamic was the very thing that Scully was so interested in, the advanced capitated payment. So basically, the money comes in, it's in the bank, and the Medicare Advantage plan doesn't want to take it out of the bank. So they figure out ways to either get more money in through upcoding, through risk adjustment, or to hold on to that money through denial of care. So this is the dynamic that we see now over and over again in the healthcare system: overbilling, under-delivering. And we see it through what Scully ends up doing after he leaves government and essentially created this system, which is a model not just in the public system through Medicare and also through Medicaid, which is largely managed care now, but also ports over into the private delivery system of healthcare. So what does Scully do after he leaves the government in 2003 after passing the Medicare Modernization Act? He joins Welsh, Carson, Anderson & Stowe, which is the largest private equity firm in healthcare and really the innovator of private equity in healthcare. The first real major private equity firm to get into healthcare. It starts in 1979, really says we're only going to go into two businesses, technology and healthcare. And their primary method to doing this was hiring people who knew the system, who knew the ins and outs. In the case of Scully, who invented the system. They have other people on staff who were major hospital CEOs. They have people who were major insurance executives. They have other people in the government who put together various parts of the system. Welsh Carson's funded 100 different healthcare investments since the early 1980s. The dynamic is usually they come in before other private equity firms. They open up parts of the business, clinician practices. For example, U.S. Anesthesia Partners was kind of an innovator in that. And there are several other examples where they're at the beginning, things like home health care. So what has happened in the 20 years since Scully signed up with Welsh, Carson, Anderson & Stowe? First thing we've seen is more dramatic consolidation on every side of the health transaction. One thing that I talk about a lot, I call it concentration creep. If you have a transaction, a healthcare transaction, and the insurance companies are getting bigger, in order to maintain leverage within that transaction, the hospitals, the providers, those parts of the system have to also get bigger to compensate for that. And one of the ways that this happens is through the role of private equity to hold these portfolio companies for 3 to 5 years and then sell them off. Because inevitably, who do they sell them off to? They sell them off to the big guys. What we now see in the public side of the business, the largest, the sort of legacy of Scully, the largest 5 Medicare prescription drug plans control 75% of the total population of subscribers. The largest 5 Medicare Advantage plans have about 63% of all enrollees. Private equity roll-ups on every side of this business, on the provider side. And these Welsh Carson investments are eventually sold into the big guys. When the companies end up getting this to this level, and they keep having this arms race of getting bigger on one side and getting bigger on the other, and they can't make their margin off of each other, who do they go to? Well, they go to you guys. They go to the doctors, and they go to the patients to end up achieving that margin. I'm going to give you two case studies from things that Scully did during his private equity career over the last 20 years. The first one is called Navi Health. Has anyone heard of Navi Health? Yeah, they do post-acute care bundling. Is what they do. They created essentially an app, an algorithm that funnels patients to what they call the proper care setting, the proper length of time. As we know, Medicare pays 20 days after the post-acute care. And so what Navi Health says is, okay, give us your patients. We will, through our app and our algorithm, give them the right care setting, and we'll take the risk. And if we get them out of here, before 20 days, then we get the profit. This was launched in the early 2010s. It was relatively successful, signed up millions of Medicare Advantage patients. Then Welsh Carson exited. They sold it first to Cardinal Health, and eventually it was sold to our friends at Optum, which is obviously the business side division, United Health. The algorithm, it turns out, would recommend a set number of care days and then cut patients off if they exceeded that limit. Patients would have to spend down their savings to pick up the treatment costs, because Medicare would then cut them off. And the algorithm ended up deciding, the level of care and the type of care, not doctors or families. And obviously, this ended up being very tied to the profit motive. So there have been a lot of stories about Navi Health, a lot of investigations, and ultimately, this ties into, I think, what we're going to see if you want to look out to the future of healthcare, which is AI's role and AI's disruption in determining patient care. So that's case study number one. That's the first thing that Scully put together. The second thing he put together is a company called Innovage. Anyone heard of Innovage? They're another person who's heard of Innovage. This leveraged a program called PACE, which is the Program for All-Inclusive Care for the Elderly. This is a government program that offers comprehensive 24/7 health and social services. It's mostly for dual eligibles, Medicare and Medicaid, frail, older residents. The idea is, if you combine personal care in the home, physical therapy, make all their medical appointments, do prescription drug delivery, transportation services, you open a day center so people can have sort of a community-based level of support, that this will keep people out of the nursing home. And PACE gives Medicare and Medicaid PACE $90,000 per patient per year. And the PACE program assumes the risk. Once again, it's a capitated payment. PACE program assumes the risk of keeping within that budget. The goal is to prevent nursing home admissions, because that ultimately is more expensive than that $90,000 figure. So Scully, before he got interested in PACE, they were all intended to be nonprofit actors. Scully got the law changed to change PACE from a nonprofit to a for-profit system. He called up his friends in Washington, CMS, and they did a regulatory change that allowed for-profit systems. And then he got together with this company in Colorado that was doing PACE called Innovage. And Welsh Carson invested in Innovage. They started rolling up PACE providers in other states, New Mexico, Pennsylvania. But, once again, the way that Innovage made money and the way it could increase growth is two ways. One, enrolling as many people as possible, and two, limiting as much care as possible. So it would get that $90,000 a year per patient and look to minimize payouts. And there were allegations. There was a whistleblower lawsuit by a woman named Karen Lapsowicz, who said that there were, denying thousands of medically necessary services to patients. One audit in San Bernardino, which is not far from here, found that 87% of care orders at the InnovAge Center there were outstanding for more than 30 days. It's all, because this is an all-inclusive program, patients cannot get care anywhere but either InnovAge or the ER. So they have nowhere else to go if they're being limited on their care within the PACE system. And then on the other side of this was the increases in enrollees and increases in growth. Sales employees were signing up homeless individuals with hotel addresses and enrolling basically anybody they could to get that $90,000. Eventually the nurse Lapsowicz, who raised these issues, was fired. She was retaliated against, but ultimately, because of media reports, whistleblower lawsuits, et cetera, CMS eventually suspended new enrollment at InnovAge at several facilities, sanctioned them in various ways. Of course, what happened to Welsh Carson? They did fine. They exited the investment in 2021, an IPO that far exceeded the investment that they put in. They did a dividend recap in 2019 that got millions and millions of dollars out of this business. The private equity company did fine, patients not so much. So over and over again in these private equity deals, and also on the public side of the business with regard to Medicare Advantage, we see the same issues: overbilling, under-delivering, and putting obviously not just patients, but also doctors in this terrible position that I often see referred to as moral injury. We're seeing now the government make some modest, very incremental changes. There have been crackdowns on Medicare Advantage upcoding. Of course, they've been delayed. They're, because of a lot of lobbying, they've been delayed, like the entry of these various new payment reforms. That we have negotiation of prescription drug prices in Medicare for the first time, but we won't see the benefit of that until 2026 on 10 drugs. And then annually, it will step up from there. But we do have sort of a start of a backlash to this constant 40-year plus system of privatization, overbilling, under delivery. I mean, by and large, we still have a private delivery system in healthcare. We have a mostly private insurance system, and half of the $4 trillion in health spending comes from the government. And Scully's belief was that this privatization put skin in the game. It would lead to more efficient care. It would reduce overutilization. It would reward quality. And I ask you, the people in this room who actually deal with this system, is that how it's working? And usually the answer I get is something very cynical like that. It does not seem better for patients. It does not seem better for doctors, but it is the way of the world and the way that we're going. I think I actually talked to Scully for this story for an hour and a half. I watched like every scrap of tape that he was ever on, C-SPAN or anything else over a 35-year career. I think he's sincere. I think he really believes that government price fixing is an inferior system, and that this system of capitated payments, skin in the game, is the way to go. But we now have 35 years of experience with this privatized system. And I think we can draw some conclusions at this point. I'm inspired by the activities of doctors here who are finally looking at this system as it is and saying we need to make a change. I think that, as Brendan Ballou said yesterday when I was here listening to him, you guys do have a certain amount of power within this system. Because you are listened to. You are, as patient advocates, as people who are generally respected by the system, you do have the ability to make change here. And so that's my story, and I'd be happy to take questions of any kind from people.
And when you talk, go ahead and talk, and then I'm just not sure if the mic will pick it up. So
yeah, I'll repeat it. Sure. What's your name? Patricia?
I'm Patricia, yeah.
And where do you
Austin, Texas.
Oh, okay, great.
So how do these Medicare managed plans that offer patients, and you talk about the gym members, but some of them, my older brother is now living with us, but he had a plan from Miami when they were that gave him like X number of dollars a month, you know, and I actually watched him do an advertisement previously and after for a Medicare Advantage plan that, you know, offered, I don't know how many thousands of dollars every quarter to help pay you rent and buy healthy food and yada, 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 and all these things. Where, I mean, I know they're not just benevolently giving away money.
Right.
So how does that fit into the picture? How do they end up making money if they're
right? So the question is, Medicare Advantage offers all of these benefits, all of these perks to individual patients. How are they getting the money? How is this a profitable system for them? And the answer is it has a lot to do with that capitated payment. They get the money up front from the government. They say, okay, we're going to take care of you. It's $16,000 a year. We're going to give you $16,000 per enrollee. This is the government talking. And go do what you want. Call me next year, and maybe we'll get 5% more next year. So then the Medicare Advantage can do what they want with that money, and some of that money goes to this essentially marketing, right? It's a way they're passing some of that money that they take onto the subscriber, but they're keeping the cost down in terms of actual care so that they are able to make a profit. So it's really, yeah, they're kind of, you know, you can look at it as a pusher giving a little bit of a hit to the subscriber, to the patient, to get them onto the plan. And then there are, you know, several other really bad options, because Medicare Advantage generally is good coverage until you have to use it. Right.
Yeah.
So
doctors, so they walk through my door, they say I have good insurance.
Right.
And I say, that's great. Do you have Medicare or Medicare Advantage? They don't usually know the answer to that question, actually. Right. They don't understand.
Right.
Then I ask them through a series of questions, and I figure out they have an Advantage plan. And I'm like, unfortunately, that tumor I can see in your lung, we're going to have to ask for permission first before we can biopsy it.
Right.
That takes 2 weeks while they freak out. And they're mad at my office, but we can't do anything about it. Right. Then it comes back as lung cancer. Then I have to ask for permission to do a CAT scan. She gets denied and have to do a peer-to-peer, so it takes another 2 weeks. Then I have to ask for permission to give them chemo, which nowadays is actually getting denied frequently, which used to happen. And the whole time they're like, I don't understand. I bought this plan from UHC that my local insurance broker, and it was great. What happened?
Right. Again, it's denial of care is kind of central to the whole Medicare Advantage construct. And then there's a real problem that happens. So what if you're a patient, you hear all this from a doctor that I actually, if I try to use this coverage, I can't really use it very well. Okay, I want to switch. Well, the rule is, the Affordable Care Act tried to get rid of this whole denial of coverage prior, pre-existing condition kind of situation. If you move from Medicare Advantage into a private plan, Medigap can now deny you coverage for a pre-existing condition. And so it traps people in Medicare Advantage because, without a Medigap plan, you pay 20% of the costs, and 20% of a chemotherapy treatment is it's not something that anyone is going to be able to manage unless you're quite wealthy. So they essentially trap people within this Medicare Advantage plan. And this is true in 47 states. Medigap is allowed to deny coverage based on pre-existing condition if you initially subscribe to Medicare Advantage. That is the real sort of jaw trapping shut on this system. And it's something that I think is of great dismay to a lot of people once they realize what they've gotten themselves into. Yeah, go ahead.
So I got it.
And what's your name?
I'm Denise Pruitt. I'm an anesthesiologist
Okay.
in Alabama.
Okay, great.
And this is specifically with my parents because I've been fighting with them to try to change. They had Medicare Advantage. And like any lay person, they believe everything that's been told. We were not knowledgeable, and I've learned a lot with them, and kept saying, well, we need to change to Medicare traditional or regional. Finally, they did change. And my mom worked for the post office, so she also could get the federal one. But I heard something like that, and I did not know the name of Medicare. But I heard that, oh, they allowed them to change. Now, you're saying that if they have pre-existing conditions, they might not cover that. So
they can underwrite it. I mean, the point is that Medigap can underwrite, they can deny in a way that nowhere else in the health system is this allowed anymore after the Affordable Care Act. But it's allowed in this very narrow part of the system where if you got into a Medicare Advantage plan first, and now you want to switch out of it into traditional Medicare, if you want that gap coverage, they can underwrite.
How do I know if that was exactly? Where do I look that up now? Now right. I'm worried that they did change and that's not covered.
Just to clarify, that meaning they'll exclude that condition.
20%, yeah, they'll exclude the condition.
Yeah, they'll exclude
like they used to.
Yeah. It's basically a reversion to the old system of
so let's say one of them had cancer, which is not that, but if they had cancer and they excluded that, where do I have that information? That
you're in the federal, like Blue Cross Blue Shield Federal or whatever she has, it would be in that policy. It'd be written in the. It
would either be in the policy or they would say we can't cover you to begin with. So I mean, if they already got the coverage, you know, they at least got some sort of level of baseline coverage. But what they might say to someone who presents and then shows their entire medical history is that, oh, well, you have cancer. We can't cover you. We're not going to cover you. Or we're not going to cover you for cancer.
And let's say they told that to them and they didn't understand. I'll look that up with the Medicare traditional. How about the federal plan would?
No, it's the federal plan that would have done that. The Medicare traditional covers 80%.
Right.
No questions asked.
Oh, it's the 20%.
Right.
So it's that 20%.
This is the gap plan, and those are private plans. So, you know, with Medicare, traditional fee-for-service Medicare covers 80% of all treatments through you know its coverage benefit. Usually, most Americans who are on traditional Medicare then get a private Medigap plan to fill in the gaps. And if they opt for traditional Medicare first, then that Medigap plan is usually covered. They can't underwrite. But if you were in Medicare Advantage first in 47 states, they can now exclude you on the Medigap side. So then your parents would be liable for the 20% on any service that they receive.
Can they move to these other 3 states and
inflated 20% wasn't that big of a deal. Like if you got a CAT scan for $200 and you pay 20% of it, who cares, right? But now the hospital is charging $10,000 for the CAT scan. 20% of $10,000 is a lot of money.
Right.
Which is why you can go do cash prices.
Which is why I just send them to get the $200 CAT scan.
Which and by the way, and Medigap coverage is not very good coverage.
Certain things that
no, it's not DPC. It's not DPC. It's just that we found pricing for our patients at other places that's cheaper.
Yeah.
So the direct primary care and direct specialty care world are more familiar with the fact that if you just don't use your insurance and pay 20% of a giant made up number, it's just actual cash and it's $200.
Yeah.
Right.
And I'm not saying that's all you need. I'm just saying like it becomes.
You can get around it. But I have a question. So on Medicare Advantage. I live in a rural part of Missouri, which means most people still get all of their insurance through their local insurance broker they sit next to in church. You know, that's who they buy all their auto.
So they get a private
So
plan.
they're all on Medicare Advantage because there's no point, you're not gonna sell CMS to a patient, like there's
Right.
no. So I'm very highly saturated Medicare Advantage population. I'm a cancer doctor, so all my patients are sick. And how do they drop people? Because I have patients that get dropped after they get diagnosed.
Right.
How is that?
So the denial of care side of this for Medicare Advantage is not really well understood or well studied. I mean, this Inspector General report that I mentioned before was one of the first to actually show these denials of coverage. Usually it's through delay. It's through the kinds of things that the other doctor talked about through, you know, oh, for 2 weeks, we gotta wait. We gotta get prior authorization.
Long enough, they die.
Yeah.
That's exactly what they are. That's exactly what they do. They die and
Right.
it doesn't matter.
Right. So, for a long time in Washington, Medicare Advantage had sort of a built-in system of support through members of Congress who would hear from their constituents. I love my Medicare Advantage plan because you know the people who can still talk say like, yeah, this is a good plan. Yeah, and so every year, year after year, there would be letters sent to CMS saying from hundreds of members of Congress saying, please do what you can to benefit and bolster Medicare Advantage. Don't do anything to hinder the system. Over the last year or two, we have finally seen a bit of a breakthrough, particularly on the Democratic side, with members saying, actually, this is upcoding, this is costing the government a whole lot of money. That's going right into the pockets of corporate healthcare, corporate insurance in this case. Also, they appear to be denying care and coverage to my constituents. So we're starting to see that worm turn. One of the reasons why Medicare Advantage was very protected is that one of the biggest Medicare Advantage plans is a partnership between United Healthcare and AARP.
Oh
so AARP, which is an advocate, right, is also making money off of selling Medicare Advantage plans. And for many, many years, they were foursquare in favor of Medicare Advantage. When you ask them about it directly, they say, look, we represent our constituents and we're not benefiting one part of the system over the other, but it's very clear from their actions what is going on. But you know, the Biden administration has attempted to do some reforms, particularly to the upcoding side of things. As I said, they instituted some of them, but they were delayed. And then this year they have to sort of reinforce that. So we're seeing another fight this year, and it's playing out like kind of right now. So, you know, if you wanted to talk to your members of Congress and representatives, this is a good time to inform them about these issues within Medicare Advantage and getting CMS to crack down on the upcoding.
And on that note, we're probably planning before August to go back to DC to push the ER Safety Act and then this stuff.
Yeah.
Can I ask?
I actually have a couple things in the chat which I could ask just spell out. The first one is from Christopher Garofalo. Scully may believe that his way works, but what data does he have to show that this is improving care and improving outcomes?
So I saw that one. I just want to frame that too, because you had an 1.5-hour conversation with the guy.
Yeah,
that's impressive. I think what was the other book? Davos Man: How Billionaires Devour the World.
Right.
Peter Goodman.
Right.
And
Peter S. Goodman.
I think he might have talked to who's the guy from Salesforce.
Mm-hmm.
Otherwise, I don't think anyone spoke with him. So I'm impressed that this guy spoke with you and he believes it.
And look, he's a very gregarious guy. Everybody I talk to who has dealt with him is like, oh yeah, he's a great guy. He's you know, I don't have a bad thing to say about him. He knows his stuff. He's very knowledgeable. He will, you know, sort of dazzle you with numbers and usually numbers that lead to his worldview. I mean, the kernel of truth in Scully's kind of ideas, you know, his value system is that, you know, after the institution of Medicare in the 1960s, the combination of fee for service, it did raise prices in a significant way. It did have, there was sort of an unchecked level of cost increases in the system. That is not actually true today. I mean, the ACA did institute some reforms that have bent the cost curve, as it were, and reduced Medicare spending to some degree. However, we know what the cost of that has been, right? The cost has been patient services. The cost has been what doctors get out of the system. The cost has been more privatization. I mean, the ACA was really a consolidation machine within healthcare. What we've seen in the last decade or more, there's a study out of the UC Berkeley that shows that 90% of metro areas have highly concentrated markets when it comes to healthcare. I mean, I'm not telling you anything that you guys don't already know.
We see on the freeway with the billboards.
Yeah, absolutely. It is true that there might have been something that you could call a problem after the reforms in the 1960s. But whether this solution is the right solution, I think is highly contested and contestable. And, you can sort of manipulate the numbers to make it show that, oh, yeah, see, we're more efficient now. And we're improving care to certain degrees. But, I mean, you look at the life expectancy statistics over the last 5 years. You look at the number of doctors leaving the system. There are a host of warning signs that are flashing red here.
I mean, we're all physician scientists, so like when you do a study and you look for signals, like the experiment has been running for what, 30 years now. Obviously it's not working. Nobody's better. We're not spending less on healthcare, we're spending more. We don't have better patient satisfaction, it's worse. We don't have better doctor satisfaction, it's
right.
Worse.
And the whole idea of this was, we're going to get better outcomes, and then we're going to lower the cost of care, the hit to the federal budgets. And what we know is that the United States spends more per capita than any other country in the world on healthcare, and their outcomes are worse. And it's sort of, what is wrong with this picture? Can we figure out a better way to do things?
Well, and for like I speak to the state legislators sometimes, and I'm in Missouri, so some of the other cattle farmers. Our governor has a high school diploma, so does our lieutenant governor, cattle farmers. But those people understand things like, well, do you think they're really losing money if they're giving the patients free grocery gift certificates? They're like, oh yeah, that's true, because they understand that kind of thing when you say it to them.
I don't understand how we got into this, late stage capitalist dystopia where these vultures are allowed to make money off of this basic human need, right? Which I feel a lot of the ills are, people are allowed to make profit off of something that fundamentally you should not be able to make a profit. Like you shouldn't be able to deny chemotherapy so that your yacht can have a mini yacht inside.
Right.
Like, that doesn't make any sense.
Like transparency and marketing.
This dovetails with a comment that's in the chat. This is from Marlene Wuss Smith. We had multiple people come in when she's talking about she's a pediatrician, and she's talking about her 87-year-old father. He had traditional Medicare and reportedly a good private Part B plan that is still being paid for. He was in a New Jersey emergency room for 2 days and an inpatient room for 1 day. And the stay was deemed to be observation. They had multiple people come into the room asking my sister, she's saying, my sister, my stepmother, myself, to sign a form to acknowledge that this was an observation stay, that Medicare would only be paying 20% of all charges. I asked to see a charge master. It was not available. Ultimately, he was discharged on home hospice. And she's asking about how hospice payments work within traditional Medicare Advantage, and those with Part B plans. I mean, this is the really scary part of the system, is that private equity has gotten into hospice.
Yep.
And that they have found that there are benefits to, you know, elongating stay, putting people in hospice that don't need to be in hospice, so they can extend the stay because they get the payouts from Medicare,
Yep.
because they get the payouts from, you know, in some cases Medicaid, you know, trying to like sign people over into this system, to get doctors and nurse practitioners more so to encourage patients to sign their loved ones into hospice, push them into this system.
Actually, that was harder to do because the so I am a hospice director as well, since I'm an oncologist. So since CMS has fairly decent definitions for hospice eligibility, when they realize, because I work for that company, Compassus Hospice is basically a private equity owned now and took over all the local hospices. I worked for them briefly. And when they couldn't pressure people that didn't qualify, they couldn't pressure the medical director to qualify them. In that case, it was me, but now they've all gotten smart enough that they've added a palliative care service line. And that's a very dubious definition. You don't even need a terminal illness, but they can use all their same hospice staff to deliver it. They can send the NP out to bill. They can send their nurses out. So they actually can capture all of the people that don't even qualify for hospice onto palliative care, because there's no real good, it's very great. And then for those of them that do deteriorate, they're already in the pipeline, so that on paper, all they have to do is switch them from that palliative care to hospice. And that patient and that family, it would never occur to them to like look at another agency or anything, because they're already seeing those nurses, they're already seeing. So it's a very good business model.
Yeah, it's a pipeline. I mean, it's a pipeline is what it is.
And then predictably, as we've all witnessed as physicians, they went from having RNs go to the house to an LPN model. So it's cheaper. So there's now an RN supervising half a dozen LPNs. So the patients are not even getting an RN visit. They're getting
and let's just say home health and telehealth, this is really the next frontier. I have a funny story. Last year, I attended Politico put on this healthcare summit in DC, and I attended it, and every other panel was about telehealth and about home health. And one of the people speaking was a member of Congress who was big on telehealth. He was I believe he's a doctor. And he was speaking, he couldn't be down, this was in Washington, and it was several blocks from Congress, but he had a votes going on in Congress, so he was remote. And he was talking about the glories of this is going to be able to expand care, particularly in rural areas. He's from a rural area of North Carolina. This is going to expand care. This is going to give us the ability to give people, you know, coverage and tests and stuff. And then his Zoom cut out. Like in the middle of the service, just perfect. And I was the only one who laughed in the entire room. Nobody else saw the ridiculousness of this, that this is the guy who's talking about the glories of telehealth and his Zoom cuts out. Imagine if you're a patient and your Zoom cuts out when you're trying to get, you know, needed care.
And I don't have cable internet because I live in the county, and none of my patients do either. And we don't even have cell signal in lots and lots of areas. And this is flat Missouri. There's not mountains. There's a hill. So I cannot most of the time successfully deliver a telemedicine visit with any of my patients, because even if we can connect, which we usually can't, you get circle of death, it drops it multiple times. And even while you're actually on the connection, the internet bandwidth is so slow because people are on like cell bandwidth. And
now you're talking about one set of monopolies making contact with another set of monopolies, and that's the telecom system.
Then they need to
you know, we have examples of really successful public fiber optic broadband companies. For my book, actually, I went to Chattanooga, Tennessee. Chattanooga, Tennessee has the best fastest internet in the world. It's a fiber optic system that was built through the American Investment and Reinvestment and Recovery Act. It's 10 gig internet And it's built this entire cottage industry of, there's a huge 3D printing business in Chattanooga, and all kinds of telemedicine, teleeducation services. It's created incubators for new products and things like that. And so what AT&T did is it got its friends in Tennessee to say, if you are outside, this was done through the electric system, the electric board in Chattanooga, and said, if you're outside the electric coverage of Chattanooga, you're not allowed to have this fiber internet, even though they were willing to send this fiber to the home. And so 3 minutes outside of Chattanooga, Tennessee, you have people with dial-up who have to go to Starbucks parking lots to catch Wi-Fi to do their homework. And so this is another why we can't have nice things part of the system. And in this case, in the case that we're talking about with telehealth, it interacts with the ability to deliver care.
So just going off
the
AT&T thread, there was a fellow of the American Academy of Pediatrics who had previously partnered with Coke back in the day, where it was like, is it appropriate for your child to have a cell phone? And he put in his 4-year-old's demographics, and at the bottom, when he pressed enter, it said, absolutely, your child's ready for a cell phone. Here's the AT&T link.
Exactly.
So
and give them a Coke with.
Yeah.
Can you comment on what do you think is going to happen with Medicare Advantage when you see all these big hospital systems announcing we're no longer going to take Medicare Advantage?
This is a very interesting trend.
It's Santa Cruz.
This is a very interesting trend for people at home. Health systems who are saying we're no longer taking Medicare Advantage coverage. This is very recent. I'm not sure.
Expensive.
Right. For the system. I mean, obviously it's knuckling down on payments and these types of things. So health companies are saying we're out. We're not taking Medicare Advantage coverage. And this is going to be a real hardship because you have two things that are operating sort of at cross purposes, right? You have in one sense the health system saying enough is enough with these Medicare Advantage plans, but on the other side, you have Medicare Advantage plans that are very successfully marketing to patients saying, we've got the best coverage that there is. So something's got to give there. And I think ultimately it's helpful to those who want to reform the system to see all of these things. There's another level of this where you're seeing it in, and this is a separate part of the system you might not know much about, but through pharmacy benefit managers. Which are who contract between the health plans and the drug companies. We're starting to see a lot of companies drop the PBMs, particularly CVS and Caremark, drop those PBMs because they're not providing any benefit to them. They're artificially increasing the price of prescription drugs because the larger the price, the larger the rebate that the PBM can skim off the top. And so that's creating its own sort of mini crisis, similar to the Medicare Advantage mini crisis. Caremark is CVS, the same company, and actually they're owned by Aetna. Currently, while PBMs were supposed to be like little helpers to insurance companies, over the last 5-10 years, every major PBM, there are 3 big PBMs that serve about 85% of all patients. They're now all owned by insurance companies. So Express Scripts is, I believe, Cigna, Optum RX is United Health Group, obviously, and Caremark is CVS with Aetna. So,
and I'll throw that, like we all talk about this vertical integration of the PBMs and the pharmaceutical supply chain with payment system, and everybody forgets to talk about the vertical integration of one of the most important parts, which is the prescriber. So they control the prescribers, and that's why they're not even called providers, depending on what you look, they're prescribers because they just need the legal authority to do it. So you have this massive, outflux of nurse practitioners, which you can look at Mills, and I'm on the Robert Wood Johnson Foundation's Committee on Financialization, which is a weird place to be because they did it. they created law of it. is
Right.
Johnson and Johnson money, right?
Yeah.
Right.
So, it's a little bit different now, but if you do look back, and Rebecca Barnard wrote a lot about this,
Yeah.
but if you look at who designed that program, the Future of Nursing report in the Institute of Medicine, you start seeing all these executives from United Health and Cigna and like all of these companies that basically are all
All the same players.
Yeah, they just designed the same system through that as well.
Yeah.
And creating the prescribers.
Because they're not
Now they own
thinking-
doctors, 1 out of 10 physicians, although Mo says, maybe they don't need, Motastic says, maybe they don't need the physicians, they need their patients. So they buy the physicians and then they excrete the husk of the physician.
Yes,
And they take their patients and then they just do what they will with them.
exactly.
Question from Oregon.
Yeah.
So Hayden, I'm texting back more people. You guys can
Sure.
talk.
Thank you very much,
Thank you,
guys.
guys.
Yeah, appreciate it. Appreciate it.
While we're making a little conversation, I need to connect, Brendan with Windows.
Okay. Oh, sure. So Hayden Rookley, I'll go a little closer because people can hear it.
Yeah.
So Hayden Rookley was one of the speakers yesterday, and he's one of the authors of the New England Journal article, A Doctrine in Name Only, Strengthening Prohibitions in the Corporate Practice of Medicine, which is sort of like our basis of doctrine and thought. Now, just an observation also because we have Capital Forum representative, which is much more of like a sort of an antitrust based thing. And what we're talking about Medicare privatizing, and just to add nuance to that, we could send Medicare dollars to private individual physicians, potentially. You could maybe, send DPC doctors $1,200 a year instead of $16,000 a year for Medicare anyway.
Well, that's where the HMO idea went wrong, because in theory, it is incentivized to take better care of your patients, in theory.
Right.
But the only person who's taken an oath in the chain,
And knows what they're doing.
presumably, yes, and is capable, but presumably has an ethical obligation, although unfortunately some of our colleagues are ethical. But the majority of us are. The only person in the chain with the ethical obligation is the physician, which one of the fascinating things to me doing DPC for the last 5 years and DSC is that unintentionally, I basically proved the HMO concept to myself because our patients are paying us a fee. So, right. So in my case, I get $60 a month.
Right.
That's basically like a HMO capitation.
Right.
I didn't think about it that way, but I came to realize if I take better care of my patient and they're paying me $60 a month, they need me less.
Right.
So I'm actually like, I'm not
And
making
you're taking
more money out of them.
There, as I say, there is a kernel of truth here, right?
Because I'm obligated to them.
But
to
as
take
you
better
say,
care.
it's who decides?
Right.
Who decides? Who decides that?
Because I'm not denying them care.
Right.
Because I'm a physician
No,
and I can't.
you're providing better care.
Providing better care, and my payoff is they don't bother me as much.
His idea was rewarding quality. Ultimately, when it was put in the hands of essentially Wall Street, the idea was the way to reward quality is to deny care.
Yeah. So
Rather than we're gonna.
But that's.
Anyway,
anyway, now we get you.
The Oregon thing is really, I think,
Yeah, and I
fascinating
grew up in Oregon,
because
so that's like huge. too.
Well,
because-
let's framing for 1 second, and then that's Dr. King, who's very humbly sitting in the corner as the immediate past president of ASA. So first of all, who decides that, hence corporate practice of medicine, if it actually goes to the physicians to decide, that's one thing. The other thing is, we're not just giving this to privatized system, we're giving them to, as you mentioned, highly consolidated privatized systems that has its own anti-competitive problems.
Right.
And then we can talk about the Oregon thing, but Dr. King, what was your head?
Just Chris from Seattle, and I really appreciate it as a history major. I really appreciate you filling in the context so people understand the origins and where things may have gone right or wrong. I guess the thing I would like to do, especially with this organization, is where do we go from here? And this is a several-part question. The last question is the most important one to me is, so we've heard that this system, unfortunately, is very reactionary. It takes a long time to do it. Sometimes we crack down, and then something else pops up because that's the way the free market moves.
Right.
Do you still believe that the system can be salvaged at this point if we're still doing patchwork? And the best example is if we ask for greater enforcement, well, Medicare just said we're going to forgive $75 billion of Medicare overpayment, advantage overpayments from 2011 to 2018.
Right.
So,
And then we're not even going to implement the enforcement for another 3 years. So
Right.
even if we do enforcement, we're still behind the ball. And so the second question, more important one is, based on what we're trying to do, based on what your experiences have showed, what do you think could be done and what do you think needs to be done?
Right. I mean, the problem I see is that we don't have a choice but to try to you know, reverse this and improve this. Yes, our you know, are the people in this room and the people, you know, who are coalition partners to you guys fighting an uphill battle? Absolutely, right? I mean, you're fighting against forces that have been allowed to get so big that they have endless amounts of legal help and consultant help to work and lobbying help
And votes,
to work the system the way that they want it. Does that mean that you know, you just throw up your hands and give up? No, of course you cannot. I think that's why I think this Oregon thing is really interesting, because all of a sudden we found that there are these laws on the books that could be used in such a way to really drive the bad actors out of the system. And it's a question of whether you can get the enforcement to happen at the state level, which I think is an easier road than the federal level.
If I can just add on.
Yeah.
Perfect segue. What I was trying to get to is we all identify and agree that a lot of the industry consolidation and the actors are bad. The one thing I haven't heard about, and one that I think has just as much culpability, is the government. Whether you want to say state or federal, for enforcement policies, caving into law.
Oh, there's no question. And I mean, there you have
federal government,
but there I think you have actually a larger voice to like. You're not going to go to the board meeting of Welsh, Carson, Anderson, and Stowe and get them to say, "Oh, well, we've learned the error of our ways and we're going to move on." But you know, the government, at least nominally, works for the people, and you know, there are people within the government. There are people within the government who do, I think, share these views. The fact that Mitch was able to speak before the FTC, which has seen a real sea change in terms of its posture on concentrated corporate power, is really important. And I think that they are dialed in on a lot of these issues. I think that the Justice Department, I had the ability to talk to Jonathan Cantor is the head of the antitrust division of the Justice Department just a week or two ago, in an extended session. He cares about these issues, and you know, the fact that you're seeing a lawsuit against U.S. Anesthesia Partners, the first real suit against a private equity roll up, and the consequences of that. This is just the anesthesia market in Texas, but it's broadly applicable to the kinds of practices that we see all across the country. And if you get a favorable ruling there, then I think you can move that and broaden that out to other parts of the system. So, you know, I think if anything, the government is like the easier road than, you know, trying to get the various concentrated actors to get religion and change.
Thank you.
Change their ways.
Last questions, but the one thing I haven't heard is, and you mentioned it, we all know Medicare Advantage is skewed. It's faulty.
Absolutely.
We now know that Medicare can't function without it. I haven't seen the government take any action against the insurers.
Right. And that absolutely needs to happen. And, you know, we've seen, you know, we're going to change it in the future. We're going to make sure this doesn't happen again, but that doesn't affect the accumulated years, if not decades, of misconduct that has happened through this system. So it's just, you're absolutely right to bring up those issues, and you should keep talking about those issues and raise your voice.
How hard would it be to get the government to at least correct the Medigap part of things right now, so that people could?
I think there's just a lack of awareness of that part of the system. The fact that, you know, I mean, the Affordable Care Act was a years-long struggle to get, and it was largely predicated on the fact that pre-existing conditions were something that no individual patient should ever have to deal with. And yet they still deal with it in this very, you know, small part of the Medicare Advantage system. And the people who are dealing with it are extremely sympathetic. These are Medicare patients who have acute needs and you know, and are stymied in their ability to get coverage and to get treatment. And so I think more, spotlights on that. And I'll say just selfishly in my position as a journalist, hearing from you guys, hearing from people about things happening in the system, that is a fulcrum point to make change. If I can write about that, and if I can, document and as well as the other reporter in the room, if we can document that, that gives us a way to talk to the political system.
So is that just can happen on the state level? I mean, can we individually, state by state, say our state says no, Medigap can't?
Sure. I mean, these are rules that can be changed.
But
and
it can happen as a state level rule rather than
I believe,
say,
generally speaking, because Medigap plans are private plans. Generally speaking, private insurance plans are governed at the state level by state insurance commissioners. And so the answer is that yes, you can work at the state level to change the rules around underwriting in Medigap. Yes.
I have a question regarding, or was saying, and it's interesting if the physician was the one to take the payment, because right now we already have learned from the years of Q-Liance with Amazon investing in them, Dell investing in them, what happened with capitation. Sorry, I'm Mary Ellen, a family practice doctor at Northern California, do direct primary care. Now we have Crenshaw and Schreier's bill that has passed already through Commerce Committee in last summer to say, give us a year to show that, like, if we did Medicaid, Medi-Cal payments to doctors, that we could show
like the demonstration project.
And so I'm just wondering, in terms of, from your perspective, having talked with Scully and all of the things you've seen and heard, what is the best way to steward that so it shows like true data? I mean, like what we're doing in direct primary care, Milliman and the Society of Actuaries has put out, in 2020, the study to show, but it was very limited. It was like, a couple thousand people maybe through like the Eversides and the bigger DPCs. But like, when I talked to them about their new study that's going to come out this December, I told Fritz, the head of Milliman, like, you have to include the independent doctors, because even though we might be taking care of fewer patients per person, we are making huge differences when it comes to keeping people out of ERs and whatnot. So,
I think it's a really interesting model. In our Business of Healthcare series, our special issue last year, we profiled a direct primary care doctor, Stephanie, was it?
That doesn't sound familiar.
I don't know. She's in Richmond. I don't remember.
Richmond, Virginia.
Yeah. I don't totally remember the name, but she did. It's great first person report of why she moved from corporate healthcare into direct primary care. I think it's an interesting model. I'm not familiar with that legislation between Schreier and Crenshaw.
There's actually more so of all primary care bills right now on the Hill, their DPC, specifically direct primary care as that legal term, has more bills than any other primary care presence. So there's one about veterans being able to access direct primary care. Schreier and Crenshaw have theirs about Medicaid and Medi-Cal, and then the HSA bill, which is going to be presented to the House in March, is to change the tax code so that we can use HSA dollars legally to DPC.
Oh, that's interesting.
So there's more movement in DPC than any family practice bill or any other thing.
Well, and I think you have in DPC a group of really dedicated voices that can be turned into lobbying forces, which is really interesting. You mentioned the veterans. One thing that we're seeing, the VA has stood apart as it's not just a single payer system, socialized medicine. I mean, the VA is the provider, the public provider, but we're seeing a tremendous amount of privatization in the VA through something called the Mission Act that was done under Trump. And the Biden administration has not really made any move to change that trajectory. And so you're seeing tons of money going out of the Veterans Health Administration into referrals. VA has become largely a referral service for the private providers, and they don't have the same expertise. Veterans have very particularized needs.
That is in my practice. I mean, it's like I'm coordinating with his doctors at the VA who are also hating the VA and they're hating their lives there because they can't get anything done. And like my patient has, you know, he's already had a stroke, cardiovascular disease up the wazoo, he's lost vision in his right eye. I mean, it's insane. And I'm like, here's the person who's talking to him about, are you actually taking your insulin? No, like, but his VA visits are like ridiculous.
We've partnered a lot with the group.
He's not seeing.
Well, all right, hold on. So I work at the VA. Now, and I want to speak on behalf of them.
Oh, I think the VA is
Well,
great. I just think it's.
Well, let me put this in context. Let me put this in context. There are a lot of problems. First of all, the VA is not licensed to practice medicine. It's another entity, so the CPOM doctrine applies to it. There can be exemptions because we think that the government is benevolent and you know supposed to do that. Or you know, in public hospitals, same thing. Like public hospitals could potentially employ physicians in theory, right? And to be honest, they were probably better than what we have right now with these consolidated other systems. But we're also, you can kind of confusing terms, right? We're talking about privatization, but there's also a bill that's not going to pass. But it's for the VA to be able to give basically capitated payments to direct primary care doctors. And that's a whole lot different than privatizing it to HCA mission.
No
right?
question.
And
no
so
question.
you know, I'm hoping to get that nuance into the conversation about privatizing versus how about we talk about CPOM? How about you can privatize it, but you can professionalize it? How about we're actually giving that to professions, and that's actually means something. But the FTC, of course, told us we're not professionals, we're commodities. Back in the 70s. So now, and the cheapest commodity is a nurse practitioner, right? So that's kind of the way that's headed. Now, but I just want to add for Chris Kang too. So we've been talking to Warren's team, and we've been talking to others, and we've gotten just in the room, which is nice. And I think when we don't go there and we're like, we want Medicare increases, like maybe we do, maybe we need them, but like that's mostly the corporations talking. Because we're employees, so we don't get those.
Well, the patients just hear that we want more money.
Well,
they don't understand.
And the legislators.
That's all the legislators.
And then,
Why you guys want more money? You already have money.
And the lobbyists are going in there being like, they're greedy, you know? So, but I want to add this is a letter from Warren and Braun. So, this is November 2023. Today, U.S. Senators Elizabeth Warren and Mike Braun are in Vienna, sent a letter to Christy Grimm, Inspector General at the U.S. Department of Health and Human Services, urging her to determine if large insurance companies are using their vertically integrated pharmacies to evade federal requirements that limit the percentage of premium dollars spent on profits and administration, known as the medical loss ratio, or MLR.
Gaming the medical loss ratio,
resulting in sky-high prescription drug costs and excessive corporate profits. Because and the idea MLR, you might all understand that, but they try to regulate away basically profit from profiteering companies, and said only 85% of your premiums need to go to healthcare. What the hell is that? Well, now they own all of the healthcare, so they just pay themselves, right?
But there's also an exemption within the MLR for your own doctors, and this is driven United Health's purchase of various practices, because if they refer, you know, to your own doctors, that does not cover under the medical loss ratio. It's an incredible loophole.
Your own doctors, or not doctors.
That's right.
Or nurse practitioner providers. I should say providers.
Non-physician practitioners.
They're
billing widgets.
Yes, providers of billable services.
Right, there you go.
Well, that's the existential debate that I've been having with others. I've been on far left field on this one. Is insurance companies got a lot of good for doing some good back in World War II, where they had trust exemptions. But now when we talk about corporatization and corporate practice medicine, the insurance companies now, because of immigration, now own every single part of the healthcare system. They are their own healthcare network system, and yet they still enjoy certain things. They can game the system, and I'm just going to editorialize, and the government looks away from it. That to me, they own pharmacies, they own providers, they own long-term care facility, they own pharmacy benefit managers, they own etc. When is there someone going to say this is inherently, ethically, fundamentally, operationally wrong?
I will say this is ironic that we're having this on Super Bowl Sunday, because the number 3 ad right now is power to patients.
Oh,
right.
It's awesome. This is so ironic.
Right.
That is the number 3 ad.
You know, in our business healthcare series,
probably UHC.
and I mentioned some of this at the beginning of my talk, but we did a very large piece on UHC and the history of UHC. UHC is now obviously, as we know, the largest employer of doctors. It has its own pharmacy benefit management, has its own health IT, has a bank. United Health has a bank that actually lends.
And they work with PE firms.
They lend to doctors.
Physicians.
No, they lend to doctors advance payments on reimbursement that is due from United Health.
Oh my God, where's Layla? Layla's not here. Layla, so Dr. Layla, she had a PE. No, she's at a primary care practice that is a PE based practice. No, we're now owned by PE, and they're based off of Medicare Advantage. And basically, I mean, people will say, just do your notes, right? We know how the notes are in PR. And so you have this absurd number of patients that you can't keep up with. And even, I don't think she has a scribe, but she had another scribe be like, the scribe is just scribing. And she's like, I can't keep up with
the scribe can't.
Their only job is to freaking scribe, and they can't keep up with the notes. I mean, it's just absurd, right? So now after a few days, she basically gets charged $30 per day per patient. Yeah, so you can maybe get $75 of reimbursement in her private practice that she owns, just like USAC says the home.
So she's making roughly what the Casey's gas station attendant makes per hour.
Well, there's losing it. She's going into more debt.
I'm saying she owes them money.
She goes into more debt. You're actually charging. You're creating debt. You did not. The physicians did not just get anything.
But it's not even just with notes. It's if you don't make the certain number of
RVUs, you owe them money.
We will, that's how Adventist is.
Even the county hospital that way. My girlfriend, who's the general surgeon at the county hospital, she's the only surgeon for like 5 years. She was on 24/7 call. When she decided she wanted to step back and have a kid, she ended up having to pay them 20 grand because she had one of those contracts. So for the 4 weeks she took off to birth a child, she had to pay the hospital back that money.
But think about this, you're a provider.
It's like being.
You're trying to get your money from United Health.
It is being an indentured slave.
They say, okay, we don't have your reimbursement right now, but we have this bank and we can give you an advance. We can loan you some money. They're their own loans.
Their doctors.
No, it's the same as poor people where they're loaning money for the car at like 30% interest. They give them a car loan for $500 because they can't make their utility bill.
Right.
Yeah, it's the same damn thing.
Yeah, we're payday loans. We're getting payday loans to be doctors.
They're payday loans.
Yeah,
they are payday
loans. Yeah, predatory lending.
So I like this. The concept of CPOM sort of is like, all right. I've never played this game Othello, but this is what somebody told me, and they bought me a game Othello, and then my dog
with the black and white.
Yes, and then my dog ate it, so I never played it. But,
dog ate.
Well, the box and
you haven't seen his dog.
Well, yeah. So this one was one really nice, cute dog.
I've seen your dog.
Another discussion. So So Othello, in theory, it's like you can be losing the entire thing, but there's like one move that can flip the board and then you win.
Yeah.
So you change all the colors basically.
I see.
That's how I see CPOM, and because you know what, and
the one weird trick.
This goes back to as a historical basis and a legal basis. And if you look in Oregon right now, everybody's freaking their shit out. So if you go to the website, all the people you want to be freaking their shit out are freaking their shit out. So I think we hit something here. Right?
What I've heard is in Oregon, two of the biggest opponents of the bill are telehealth companies, even though they're exempted from the bill, and Amazon. Amazon owns One Medical now.
And
they just fired all their employees because they're basically going to have a nurse practitioner rubber stamp and AI generated whatever makes the most money.
Right.
Because again,
so
they don't
Amazon is a huge lobbyist against the Oregon plan.
Yeah.
So
it's going to hamper them.
So Amazon, and then it sounds like a bunch of people on the PACE program. That's why we need to talk about that. So there's some PE roles as a nonprofit insurance company.
There's also the other reason Oregon's gonna be a really interesting test case is because Oregon, as far as non-physician billing providers, is the wildest state in the 50 states and always has been because Oregon's interesting. But if you're on Oregon Medicaid program, your primary care physician can be a naturopath, a chiropractor, an NP, or a physician.
Yeah, they have independent practice for everything. And so the ironic thing is, so if you go to the Oregon, I put it in the chat somewhere. If you go to the Oregon website or the legislation, and you go to testimony, like we put some testimony in there.
Which one is it?
It's in the chat. sorry, I'll find it for you guys if you're not on the Zoom. Yeah.
It's a lot. We're not-
I have to, it's also on Take Medicine Back Facebook group, but I'll have to send it to you guys here. I'm logged into Zoom here too, so I can watch the questions,
You
but
can watch yourself there.
yeah, I can, I've been monitoring the chat. That's what I was doing yesterday. So, you can look at the testimony. It is overwhelmingly positive. We put in testimony, ASAP needs to. And I know you can't do, well, I'll tell Asia, yeah. So, but AEM, Take Medicine Back, and then long list of people. No, the only group that opposed it as of when I last checked was a radiology roll-up.
That's really private equity, but they're pretending like they're doctors.
Yes, it's Epic Imaging, and I don't think related to Epic, the EMR, but and then it says underneath they talk about it's Reyes, which is a PE roll-up. They're not Welsh Carson, but they feel like it.
They're aspiring.
Yeah, they're like Welsh Carson wannabes. And so nobody else opposed it publicly, because when they do it publicly, they expose that they're assholes, which is great, which is more we need more light, to expose this. But you can check, the naturopaths are on there being like, we support this legislation. But you know what? That's where we actually do have the NP support it. And NP was like, they came in to try to, well, some of them do, not the corporate ones perhaps, but nurse practitioners. So I'm like, I saw your your testimony on the Oregon bill and wanted to join Take Medicine Back. And it's like, we are worried about scope, but it's really kind of scope underneath corporations, because they're not fighting for independent practice. They're fighting for no doctors, and because they're not independent, 95 to 98% based on Bureau labor statistics are working for corporations. And we're like, oh my God, 74% of physicians are working for corporations. We freak out. They were born by corporations. So anyway, the interesting thing is it's massively overwhelmingly positive testimony. You can also watch the video. And then you have the Amazon tech guy that goes up and blah, blah, blah. He's like innovation, and he's on Zoom. It didn't cut out. I wish it cut out, but he's on Zoom and he's got this greasy thing. And he's like, we're doing innovation. But they pissed off the chair, and people there are like, you're extracting from, they see them as outsiders extracting from Oregon. And that was a place that they could really hit some nerves. But
that made sense to them.
But the key, I think, is the corporate practice of medicine doctrine was created in the late 1800s and early 1900s, and the beginning of insurance. Maybe it was like
basically to stop snake oil sales.
Oh, that's the other thing. Yes, okay, so
it's like designed to stop the advertisements that you would have of take this elixir and
so there were
so and so said
so there were two components, but one big thing to think about is that we haven't reinterpreted the doctrine in light of insurance companies.
Correct.
So the payment system, which they're not, it was
let alone corporate.
So it was about lay influence on the practice of medicine. But at the time, the only way to do that was by employing the doctor. Now there's lay influence over the corporate practice of medicine by the payment system, even for our basic payments, which direct primary care fixes the basic payments, because now we can go back to very affordably take care of patients for 90% of the stuff, which is, I think, by the way, if we can get DPC combined with funding EMTALA and sort of let's make insurance actually work for the big real emergencies, and everything else you go directly to your doctor for. That's where I think we could do some kind of fun.
To me, it's really all about who directs and controls, right? If you're in a position as a doctor where you don't feel like you're able to provide the treatment that you feel like the patient needs, that under your oath you feel like this is what we have to give the patient, then you're not in control of your own destiny. And that's ultimately, when I talk, just in a broader sense, I wrote this book about monopolies, and over again, what I heard from farmers, from people in journalism, from virtually everyone that I talk to,
loss of autonomy.
It's this loss of liberty. It's this loss of the liberty to pursue your talents in the way that you see fit. And that's at the heart of
we've been deprived of our pursuit of liberty and happiness.
Without
the process of the law.
We're suicidal, literally. Like our profession is
female physicians
is through the roof.
You talk about agriculture, they're dairy farmers. I reported on a story where they were receiving with their checks suicide hotline numbers to make sure that they were
They're gonna lose their
okay.
farms that have been in
Because
their
they're,
family.
exactly.
I think we go with every
That's who
single
we take care
profession
of is farmers.
and occupation or trade, and we go up there and we come up with like a mass complaint, a 14th Amendment complaint that corporatization has deprived of us of our life and liberty without due process of law, and then just like
Definitely depriving my happiness.
life,
Liberty, and the
liberty,
pursuit of
Right.
happiness.
Well, that's
The
yeah.
Montana
It's a
team's got
declaration.
their environmental stuff passed, so it's totally like it's
Possible.
reasonable. I had a question though about Amazon,
Mhm.
like when you talk about who is controlling, Amazon bought Iora for like 2 point whatever $billion, and that's their Medicare Advantage DPC. I mean, it was perfect for picking. It was like the social workers and the blah blah blah, and blah blah blah. But it's like, so I don't know if you've seen like, because I think about how I can't think of the name of the big corporation in like the Irvine area, but they say, oh, we have a direct primary care plan, and they're like, you know, they're saying these things. But Iora is a great example.
Insurance, but they're, is that what I mean?
No, they're totally, they're just
Well,
throwing
there has been over the last few years this attempt to apply kind of Silicon Valley techniques to healthcare, to disrupt healthcare. The first thing was Amazon, JP Morgan, and Warren Buffett getting together to create a healthcare company. And that they realized, oh wait, healthcare is hard. We can't do this. So they trashed that. The next one was CVS trying to do these minute clinics to create essentially a primary care system within the pharmacy. And that's done okay, but it hasn't really advanced to the degree it needs to. The next wave of this is Amazon buying Iora and One Medical, and trying to create a you know, this disruptive primary care system within that. When the real disruptive system is the one that you guys have created, where the doctors control rather than, you know, some tech pro who's trying to figure out how to deliver this care at the smallest possible cost.
When you talk about the control though, it's so frustrating that, like, for example, my latest run-in was because I don't accept Anthem, I can't get an IUD for my patient because they don't fill my prescription with my surgeon and license, you know, whatever.
Yeah, what's the point of having being federally like vetted, licensed, board exams, degree, all these things, and they don't honor our order.
And then, you know, we have like Adventist, you know, I will order labs, they will get done. I will never get lab results back. We have to manually ask for them. And think that's not cool either. If someone's in renal failure.
Hello?
Oh.
Sorry, I'm just setting it up.
Oh. Okay. Yeah, no, I mean, it's really heartbreaking when you hear these stories. And you know, it's like, here's the one way of people that have figured out, okay, I can go outside this system, this corporatized system. And then this is what they do to you, right? This is the hurdles that you are put in front of you.
And that's honestly, that's another FTC kind of thing, like this, that's anti-competitive, right? Like we're at such a competitive disadvantage from every single angle, and direct primary care is about as transparent as it gets and should be as pro-competitive as it gets. And it's like outright dismissed by the left and some, actually by a lot, but like left and right to some degree.
But yeah, I mean, it's interesting to think is, do you have an unfair methods of competition case around that? It's like, if you can't get the services ordered for your patients, is that collusive in some way by the various, whether it's the insurance companies or the providers of those various services? And is there a way for the FTC to say, okay, that's enough?
Well, how about, so
this
there's
is like my husband being eliminated from
an
his job, and if you wish to use your insurance in our county to see a doctor, you no longer have that option. And that's an Adventist health thing. Like, this is what I've been trying to say to the state level. It's like,
Thanks a lot.
Thanks.
Thank you all.
well, so this is to come up in the DPC over the last couple of years. So some of the hospitals have rolled up enough practices and have enough of a monopoly on the market that they're refusing our consults. That I think has a legal merit. So as like, if I'm seeing a patient for cancer and I need them to have a surgery to remove the cancer, and I send the consult to a large healthcare system and they refuse to honor it because I don't work for them.
It needs repeating.
That's very dubious from a patient care standpoint.
Without a doubt.
Do you mind if I?
Yeah, go ahead.
You
How
have
can they?
copies of
Well,
your,
you
your
can do anything
publication
until it's
this year?
challenged.
I don't
right?
have copies of it with me, but I
You can
can
do
give
anything
you
until it's
some
challenged.
information.
But yes, ethically, how
tells
can
you where
you
to
do
go.
that?
It's just prospect.org, by the way. And Business of Healthcare series, I believe it's just prospect.org/business of healthcare.
Sorry, Scott. I think, I mean, there's a lot going on here, but I think here with the FTC, there's a lot. But if we go back to CPLM doctrine, we always go back to that basis of the sort of professionals need to be the ones that control it and take our ethics back. And there's a little bit of a PR component to that. But what I'm seeing with the FTC, I'm looking at the anti-competitive journalist or anti-competition journalist. She puts all the other journalists out of businesses like Gannett. Gannett's the anti-competitive. Anyway, I mean, there are people in the government that are listening, and what I think we've been so cynical that they possibly couldn't listen, but they've also been gaslighted by a bunch of not the journalists, a bunch of the some of them, a bunch of the lobbyists are going in and they like smile and they're like, Tom Scully, he's nice, and I know him, he can't do anything mean, but we are seeing like the seriously understanding in words, and I think the best thing the Biden administration has done is Lena Khan and Cantor is that appointment. So and then the announcement that they were going to launch a cross-governmental investigation into corporate greed in healthcare should have been the headline. I think they was really bad at that PR thing.
So hard. It's like 6 paragraphs.
Yeah, I'm like, oh, that's a cool down here, and but also buried within there was that they were going to create payment systems for independent doctors. Their primary care. What does that look like? I have no idea. It'll probably get held up with lobbying. But the point is, they're actually hearing that, and this is where I think. Oh yeah, I'm trying to get screen sharing. If the host can do that. And otherwise, I was going to play the video without it, and you might.
Yes, Mitch. Here we go.
So
Please
I'm going to
play
it. Hopefully, you guys can. Oh, there it is. Okay.
And make sure to turn on the video sound.
I played this yesterday, but it was a long day. So this is at the Capitol Forum where I was on a panel with Hayden and Marco, who just left. And thank you guys for inviting me to that. And what's his name? Teddy founded Capitol Forum, I think, and so he was having this fireside chat with FTC Commissioner Alvaro Bedoya, and I think I'll bring this back enough we can listen to a little bit more of it this time, with Teddy saying we listened to some doctors today, and then he asked Bedoya about that.
On medical decisions, that was a big topic today. Was
integrated entities versus the independents, and I think we need to pay attention to that.
You said you spend a lot of time thinking about labor, so I'm going to ask you a question about labor.
Yeah.
How do you view labor in healthcare? We had a lot of conversation today, and I think the most interesting aspect of the labor wasn't just there was monopsony, power issues by private equity, but there was also this idea that non-unionized physicians and a weak labor power among doctors leads to issues around corporate influence in medical decisions. That was a big topic today, was, instead of medical judgment being used to make a decision, you have these, corporate influences or, making the decision for the doctor.
Yeah.
And I'm curious if you've thought about that, or just what you think about labor generally, when it comes to healthcare.
Yeah, I'll say three things on this. Let me see if I can remember. Look, the first is, I think those state laws about medical providers needing to be in charge of health practices are tremendously important. And I think there's a lot of evidence out there that certainly the spirit of those laws is not being adhered to. you know, there's a reason states pass those laws. It's because doctors take Hippocratic oaths. It's because doctors are experts. Doctors form relationships with their patients. I think it's a respected profession, not just because people do well, it's because they're literally taking care of people and they care. And so I think that any state official with these laws in their books would do well to make sure they're being enforced both in terms of letter and spirit, number one. Number two, I'm sure everyone in here knows doctors. I'm sure there's some doctors in the room. I think the medical profession has changed dramatically in the last 10 or 20 years, where increasingly you have doctors saying, I feel like a cog in the machine. I feel like there's someone telling me where I need to go, when I need to do it, and giving me advice on my medical decisions from people who may not be qualified to do this. I don't control my hours. I don't see the upside if the business does well. And that to me jumps out as something that is just significant in and of itself in the quality of options in the labor market for physicians. Third, you know, in the statement I did for the merger guidelines, for me, you know, yeah, I go out and visit with people because I think it's the right thing to do. Also, to be completely honest, it helps me understand, you know, what the heck is at stake. And for the same reason, I read a lot of testimony from people who come testify before Congress or before state legislatures. And for me, you know, I didn't, everything around labor crystallized when I read this testimony of a nurse. And she was a nurse up in Pittsburgh. And she said, hey, look, the COVID pandemic hit and and we weren't getting PPE. And so I went to my boss and I said, we need PPE, we need hazard pay, we need to be treated better. This is a dangerous situation. And I forget what exactly she said the boss said, but it was some version of, you know, go pound sand. And so she started looking for new jobs. And, you know, she went online and and I may be getting specific aspects of this off, but it's all in the statement. The right version's in the statement. But she goes, and first it's like 80 listings, and then when she eliminates, okay, well I've got kids at home. I can't work nights, and I actually don't have a car. I can't do these long commutes. I need public transportation, and you know, it was a very large number, and it went down to I think 1 or 2 openings. And this is a nurse, right? This is a good job, and yet, when she looked at the labor market for her profession in her area, you know, it was either stay where she was or maybe have a shot at 1 or 2 other places. Maybe, right? That for me crystallized so many aspects of this, both how long it takes to look for work, the fact that, you know, people aren't toasters. Toasters don't care to whom they're sold, when they're sold, how, you know, how often they toast. You know, we care about that. You care who you work for. You know, the person who is buying your labor needs to decide that they want to buy your labor. And so, but I think the last thing that jumped out at me is what she said. She said, you know, 20 years ago, there were something like 15 or 20 places I could have worked right in my neighborhood. And as a result of a wave of mergers, that's gone to, you know, 1 or 2. And so I think that for me encapsulated what's been happening in labor markets and healthcare in a way that I think a lot of people would assume is not the case if they're not familiar. They think you're a nurse, that's a great job. You're a doctor, that's a great job. I think unfortunately some moves to consolidation and concentration are reversing those trends. And I think Chair Khan and Commissioner Slaughter and I are really worried about that.
Yeah.
So like, I mean, he talked to a nurse. We got to talk. More doctors need to talk to him. But that whole thing was about doctors and what, like, the FTC totally screwed things up. So, right, so if you put something if you put something in the Take Medicine Back Facebook group, you know, you get people angry about things, and then you get some people like, the government shouldn't touch anything. Whenever they touch gets bad. I'm like, how about they touch it in the right way? You can touch things inappropriately, and you can touch them appropriately, you know?
Good touch, bad touch.
Yeah. So,
Throw me on the doll.
Yeah. Draw a picture.
But there's been of course, it was massive consolidation and allowed, you know, going back to Bork the 1970s FTC and apparently Nixon, and then Reaganism, just like the government did do that. They have a policy. There has to be a policy, and their policy was not to have a policy about enforcement of consolidations.
Well, I mean, there's a term that often is used called deregulation, and it's actually a misnomer.
Yeah.
Because there's going to be regulation. You have a market. There are going to be rules set up by which that market is conducted. You can either have those regulations and rules set up by democratic processes through democratically elected officials and their executive branches, or you could have regulation by corporate boardroom. You can have regulation done by the C-suites, and they'll be doing it. There's going to be regulation. It'll just be in the interests of those
very
undemocratic forces. They're happy to do it. So we can have one kind of regulation or the other. It's not regulation or deregulation. There's not anarchy in American markets. Those are set up very and in this in recent years set up by private forces in Wall Street for their own benefit. So that's what's at stake. You can't just say, "Oh, the government shouldn't do it," because into that vacuum comes
that's
Wall
where
Street.
you pull doctors in, because a good doctor, if you tell them their patients are at stake, they're a lot more willing to do a lot more things. Because look at all the things we've sacrificed for our patients. I mean, many of us have sacrificed marriages and all sorts of things for patients.
And of course,
the decisions.
Well, and also just I don't think there's a legal concern here, right? But the concept of DPCs, we're not insurance, because we're not taking on significant risk. Right. So it's a little different from that perspective, because they're not capitating like, oh, we're going to lose money if I have to do a CT on this patient. Right. But anyway, we can have democracy, or we can have power concentrated in the hands of the few, and we can't have both. Right. I think there's just like
that was Louis Brandeis.
So get back to that. Well, and the Brandesian school of thought, right, which is the Cantor and
Brandeis movement,
and Lena Khan.
I remember in 2017 there was this conference. It was actually at the University of Chicago, which is ironic because the Chicago school is led by Robert Bork, is seen as the institution that led to the hands-off on consolidation. But in 2017, there was this conference at University of Chicago, and we were all there. A bunch of us more aggressive antitrust reform types. And I remember the last night of that conference, there were a bunch of us at a table thinking, we're all out of power. What are we going to do to get any kind of measure of power? And the people at the table were me and a few other people, and Lena Khan and Jonathan Cantor and Tim Wu, who was the antitrust czar in the White House. And within a few years, they all got power. The idea that this is hopeless and unthinkable and things can't change, things did change in a very rapid period of time on the government's outlook toward corporate power. And whether that remains is a question of that'll be decided in the elections in 9 months. But it's not impossible to make progress here. And I think what this group is doing is really a step in the right direction.
Appreciate it. Sounds like, I want to ask earlier, this Oregon CPOM legislation has a lot of people worried, right? So it sounds like a really good place to crystallize out of physician efforts, right?
Yeah.
What's the best way for your average lay physician or someone in this room to help advance that bill?
I mean, that's a good question. I think that, first of all, members of legislatures typically listen to their own constituents. So if you know people in Oregon, practitioners in Oregon, clinicians in Oregon, they're the ones who need to lead the effort. That's who's going to be listened to by the members of the legislature. Mitch would know better than I in terms of the active efforts that are going on right now, petitions, maybe professional organizations are putting together their endorsements. But these things have to happen from the bottom up. You know, it's about the grassroots.
We saw the state level, right? You know, I'm based in, also I'm Matt, I live in Las Vegas, solo practice, right? Nevada is a small state, right? It sounds like it's not that hard for a physician to actually get a voice at the table if they so choose, right? Would that be kind of a first step, right?
Yeah, I mean, I think and you can tell me if I'm wrong, but the impetus behind starting in Oregon, first of all, the laws are friendly there, but it's also about the snowball effect. Like if you get this done in one place in the country, it helps everywhere else. And also, you know, these systems are they're very systematized. I mean, you know, the way that a private equity firm handles its business in Oregon is the way it handles it in Michigan or New Hampshire or Georgia or California or wherever. And so they're going to have to modify their system if Oregon suddenly says, you know, you can't set up this construct in the same way. So
like now in Missouri, where they could give a crap about nutrition, the calories are on, you know, because Applebee's is in California and Missouri, and they don't want to make too many, so.
Right. So yeah, that's one example. Yeah.
Or cars.
Or yeah.
Let me ask you this: do you belong to the state medical society?
I do.
So like, if you ask that of your colleagues, the answer you'll get a lot of times nowadays is no, because when you're employed, you don't think about it. So, and then those are the organizations that you still lobby for us. And do you have a doctor of the day program, do you know, through your state?
Do not know.
So ask, because usually they do.
Yeah.
And they'll want to host you at the house, at the state level. They'll want you to go up to the Capitol, and the lobbyists that work for the State Medical Association will treat you like a king, and they'll lead you around and they'll introduce you to people. But that's how you start making friends. And when you make friends with those state legislators.
Can I answer his question too?
Listen, sorry.
Sorry, I just because I'm very specific to the Oregon component. Because I do have, I'm pretty, like, I text back and forth and emailing with Hayden and the representative Bowman who's introducing it. So I wrote testimony, and they wanted out of state testimony.
Oh, that's interesting.
They want that. I don't think they wanted it in person because they like 20 minutes, right? But so like they want somebody who's there, which they did. They got a previous governor who's a physician who did pretty good testimony, and now they have Hayden's done an awesome job of getting like different Oregon physician groups. Notably missing is the Oregon State Medical Society.
What?
And the scenes.
Yeah, why, do you know?
Well, you know, some of our doctors might want to sell to Optum, and so we can't really blah, blah, blah. Yeah, notice they're also not opposing the bill.
I can't understand what you're saying. I'm sorry.
But then go to that site and you can look at the testimony and you can see all the groups that wrote it. And it all says support, except for Epic Imaging, which is a private equity roll-up. And there's an awful lot of people fighting this. They're just not writing it down because their words will be used against them, because they'll be like, we oppose this bill because innovation and we're greedy. You know, like it doesn't work well in writing, I think. So they're doing that behind the scenes. Like Oregon State Medical Society, like I'll shame the shit out of them. Like I told Representative Bowman, I'm like, I will get everybody in the country and Michigan State Medical Society to be like, Oregon State Medical Society does not represent most physicians, and it represents only the greedy ones who are exiting the practice of medicine and shouldn't have any influence in it, you know? And that's what I
have an Oregon license, I'll come on.
Sweet, okay, and I can give you specific contact information, stuff like that. But they do have a lot of the Oregon physicians. Hayden's done a really good job. So Hayden Rookley, one of the authors of that New Englander article he spoke yesterday, and he was in DC health policy for 5 years, got disillusioned with how slow things move in Washington, and went back to Oregon and worked on this and kind of created that, you know, the legislation, a lot of it. And right now behind the scenes, there's all these groups coming in trying to sow confusion. And our usual story is, okay, but why do you need to control the doctor? Why does this need to be a fake ownership? Because everything they say, you know, innovation or whatever, doesn't require you to control what the doctors are doing. So you just always go back to that.
From my perspective of narrative, you know, as a journalist who's trying to explain this to people, I feel like the friendly doctor aspect of this is the most accessible.
Yes.
In terms of telling the public, okay, here's one guy who controls 300 practices all over the country. Do you really think he's making the decisions for each one of those practices? And you know, profiling those guys, talking to those guys, and So, you know, in terms of our coverage, I mean, we're gonna be covering the Oregon thing. But in terms of our broader coverage of this entire issue, I feel like that is the most accessible.
And keep this in mind,
I think you're right.
the
And I think public opinion too.
the medical boards can discipline physicians, including in Texas. I'm looking at you, yeah, but the medical board, that's not you, but the medical boards can discipline physicians. The reason I am looking at Texas here is because the one he's referring to is probably the most egregious known case.
Right.
Where one physician is listed as the paper owner, so the friendly physician, friendly to the devil.
Yes.
And
Captive physician.
Captive physician is the best
No,
terminology. Colluding physician, but they're captive because they are actually stripped of all power legally for that company, but they're doing that because they've got because they get money. So corrupt physician, piece of shit, sellout physician, you know, those are much better.
Narc.
But straw ownership, sham ownership, paper owner, there's so many synonyms here. And so, but the idea is that those are literally in our profession. They're not even just the ones where like private practice is hard and I need to sell it and I can't sell to another physician. No, these are ones who like a private equity company comes to them and says, there is this little annoying law that has something to do with ethics or whatever in the state that protect patients. Right. And what if we just bribe you so that you can lie and pretend you own this shit and we'll pay whatever you want? Yeah. And that guy's like, okay, cool.
Which
that's the villain
in our profession.
Yeah, and I think that villain has not been elevated to the public consciousness.
And you know why else that's brilliant?
That's I think something that needs to be.
And the distrust of the public of doctors with the perception we're greedy. If we police ourselves that way, that gives us integrity and credibility.
The question is this: in the state of California, where you have a nurse practitioner with 4,600 hours of supervised care, bullshit.
46 or 4 to 6.
4,600 hours.
I just want to make sure. Yeah, no, I know. I just want to make sure I was hearing you right.
And they're basically physicians in the state of California. Are they going to be the next friendly non-physician?
Yeah, that's what the business.
Well, so let me go there. So because I have brought this up because when people are very uncomfortable talking about scope creep, politicians, everybody's very uncomfortable talking about it. Oh, I don't want to talk about the nurses. Yeah, well, you're not a politician. And so when I talk to those folks, I usually start with CPOM and greed, and everybody can understand that language. And then I'm like, so and then independent practice state, what are you going to do about the corporate practice of advanced nursing? Because it's the same thing. You tell me how it's different. If they have an independent practice, they can order all the tests and all orally imaging and all the medications and labs and make the decision. So you tell me how that's different. So if the corporation controls the practice of advanced nursing, how is that different? Except now you're putting people who don't know what they're doing and don't know how to push back at all. And are even more probably like in just as much debt that don't know what's going on, right? So how Oregon is approaching that is they have included all of the clinicians that make this, so includes the naturopaths, includes the chiropractors. Now it does become even potentially an anti-competitive issue because guess what? There's a lot of misleading competition with the nurse practitioner, part of a nurse, and we're better than doctors. Here's all the things that say that we don't need supervision. It's all backed by the corporate interests. So it becomes another competition thing because the FTC wanted us to compete with other labor to drive the costs down, but it's an anti-competitive labor market because they are lying through the corporations. But the key is if we can expel the corporations, I mean, you're going to have a lot of NPs opening bioidentical hormone clinics that are run by corporations, but you know, they hopefully will be rightfully afraid and want to work with physicians on, you know, under actual supervision, meaningful supervision, even in a state which doesn't require legal supervision because that's practically meaningless in the first place. But that's how they're approaching it right now is independent practice states, corporations also can't employ the nurse practitioners. Then we get to go back to the scope.
Sounds like a very
great.
Thank
you all so much.
About Greg Burke